Dr. Heather Forkey is an associate professor of pediatrics on the University of Massachusetts Medical Center, vice chair for wellness for the Department of Pediatrics and division director for Child Protection Program and Foster Children Evaluation Services of the UMass Memorial Children's Medical Center. In addition to her clinical work, Dr. Forkey has been the recipient of local and federal grants to address issues of children in foster care and to translate promising practices to address physical and mental health needs of children who have been traumatized. She has published and presented nationally and internationally on the topics, serves leadership roles for the National Child Traumatic Stress Network and American Academy of Pediatrics on issues related to foster care and child trauma. Dr. Forkey, I'm going to turn it over to you. Thank you.
Great. Thank you guys so much. It's such an honor to be here joining you guys today. So we are going to talk about burnout and secondary traumatic stress, and certainly that's a topic that is probably not unfamiliar to any of you guys. I have nothing financial to disclose to you guys, and we're going to talk today about the symptoms of burnout and secondary traumatic stress. Think about and recognize the 4 types of the human stress response and how they can contribute to burnout and secondary traumatic stress. Consider the role of the affiliate response in preventing burnout and secondary traumatic stress, and then think about a strategy to promote that affiliate response in the workplace. So for us who work in child abuse and foster care, but also for all of you who work with children who have medical complexities, and every one of us dealing with COVID-19, we're dealing with kids and families who have often experienced a lot of stressors. But so do all of us who are serving in these various roles to support those kids and families. And in fact, as we do that work, we become increasingly aware of a number of concepts: burnout, secondary traumatic stress, compassion fatigue, vicarious trauma, depression. These are all terms that have been thrown around to try to get at how this work can impact those of us who are on the serving end. Most well discussed in the field of medicine is this burnout, which was defined by Christine Maslach as 3 things: overwhelming exhaustion, feelings of cynicism and detachment from the job, and a sense of ineffectiveness or lack of accomplishment. But for anyone looking more closely at burnout, there are other symptoms that come along with these original 3 factors and are frequently seen in those who are suffering and dealing with burnout. There are issues of sleeplessness, frequent illness, depression, irritability with coworkers and friends and family, forgetfulness, and working hard and feeling drained without signs of production. Secondary traumatic stress is much less well talked about in the field of medicine, but for our colleagues in mental health or child welfare, this is a much more familiar topic. What I will do is kind of try to define for you what the differences are. So secondary traumatic stress refers to the presence of post-traumatic stress disorder symptoms caused by that indirect exposure to traumatic material. There are other terms that capture elements of this definition, but are not interchangeable. Compassion fatigue is the closest term to secondary traumatic stress, and it has been used interchangeably, although there is some slight variation. Burnout, on the other hand, is really this work-related general occupational stress and not really the effects of this indirect trauma exposure. So for the purposes of today, I'm going to focus on secondary traumatic stress and burnout. Now, secondary traumatic stress overlaps quite a bit with burnout. There are cognitive symptoms that overlap, like lowered concentration and apathy. There are emotional overlaps, sadness and helplessness. Behavioral consequences like withdrawal and sleep disturbance, which overlap with burnout, and certainly physical symptoms which overlap, which include the impaired immune system and something I can't read because it's on my screen underneath a toolbar. But there are also symptoms that look much more like post-traumatic stress disorder, preoccupation with trauma, helplessness, hypervigilant, elevated startle response, and an increased breathing and heart rate. Interestingly, there is an interaction of not only these 2 issues, but a number of other issues which impact us as we go along serving kids and families from whatever aspect we do that. There are issues of moral distress and implicit bias, which have become increasingly more obvious to us as we've dealt with COVID-19. There's traumatic grief and loss. There's direct exposure to things that are traumatic to us in our own lives. Secondary trauma and compassion fatigue interact quite closely with systems failure. And there is not always a clear defining of how one is not causing and being caused by some of these other factors. But as I began to look into these topics, I was really fascinated by the fact that discussion of these issues quickly moved to solutions that really relied on the individual taking on things to fix the individual. In much of the literature around especially burnout, but some in secondary trauma, there was a heavy emphasis on self-care, yoga, mindfulness. There were some that said, if you just ate enough kale and yogurt, you'd probably be okay. But as someone from the medical field, I kept coming back to, but we have to understand what this physiology, what is happening to people biologically and physiologically. If we are dealing with these conditions, we can't move to treatment before we've really figured out what it is that's actually happening to us. And only then, once we've really thought about physiologic causes, can we really think about what solutions make sense. And so instead of sort of throwing things against the wall and seeing what would fit and what might help one person over another, could we think about this from a physiologic standpoint? And in fact, it turns out that we, who are serving kids and families, experience the same range of stress responses as our patients or the kids that we're caring for. And most of you will be familiar with some of these stress reactions. So there's the freeze response. When you're under threat, at times you just stop because the threat is being perceived as such that you can't move, that you must stay still and just be alerted to this. And in fact, maybe staying still is the most protective because in a predator situation, if you don't move, perhaps the predator will move on by. In other situations, we are drawn to fight or flight. This is stimulated by our hypothalamic pituitary adrenal axis. We have stimulation of epinephrine and cortisol. And basically, we get a surge of energy so that we can run or fight our way out of the situation. But in fact, those three responses are not particularly effective for humans against big predators. And so we also have another response, because if it's a human versus a tiger, we actually are going to be seen if we freeze, and we can't run fast enough, and we can't hide effectively, especially if you are a child or someone with children. So humans actually had to evolve to have another response that was more effective. And in fact, we did. And this is called the affiliate response. Interestingly, it is oxytocin mediated instead of epinephrine or cortisol mediated. And it has had less dissemination and that has to do with a couple of things. One is that early studies on stress were done on animals that don't have oxytocin. So it was missed because you have to study an animal who has oxytocin. And when we do human studies, initial studies were done mostly on males, and oxytocin-mediated responses are true of males and females, but are a little bit more common in females, where we see the response, which is also called tend and befriend. What happens is that under threat, humans actually can be most effective if we look left and right and see if there are other humans there who can help us. And in fact, what oxytocin does is it allows us to have an increased social salience, meaning we get better as humans at recognizing whether those other humans who are around us are going to help. And if we find that we are in a safe context where there are people who can help us, that actually allows us to move forward. If we look left and right and those other humans are not going to help us but might eat us, then the context is unsafe or negative. But if you look left and right and you find that, hey, there are some humans here who can help deal with this, we develop pro-social thoughts and actions that facilitate garnering the support of others. We actually get better at drawing others toward us to help us deal with the problem. And we then can have adaptive stress responses, which allow the cortisol and epinephrine to subside. So in fact, having studied this, perhaps one of my solutions is that we should just provide intranasal oxytocin in a widespread delivery system throughout hospitals, along with perhaps a flu shot. But of course, medicine is about dealing with threats and challenges all day long. And over time, in our efforts to deal with this in medicine, at first, tend and befriend was our first and primary natural response. In the early days of medicine, we had leeches and tend and befriend. And the leeches were not that effective, but as nurturing medical providers, we would spend time with our patients and get to know them, and they too would get to know us. And at the bedside, we would tend and befriend the family and the child, and in turn, we were tended and befriended too. As the speed and volume of medicine increased, we turned to colleagues to tend and befriend as we faced threats. If you imagine the days of Marcus Welby, the physicians might gather in the physician lounge, the nurses might gather in the nurses' lounge, and we would all smoke cigarettes together and have martinis together, but in so doing, kind of gather the support of each other. But over time, there have been a number of threats that impact our ability to tend and befriend each other. There has been an increasing administrative burden, which forces us to be doing a lot of other things besides interacting with other humans. And as technology has improved our ability to provide some types of care, it has also begun to isolate us. For myself, I used to work in a large workroom where residents would come in and other providers for the day would come in, and we would discuss our cases. But now we all go to our own computers, typing into our Epic system without talking to each other very much at all. So what happens when that response from others is negative? If we look left and right and the people that we're looking to can't pay attention to us or are otherwise overwhelmingly stressed, we actually develop antisocial or defensive thoughts and actions to protect ourselves from others. And we develop distress responses, because fundamentally what this means is that not only is there a threat coming at you from a predator, or in our case, from a complicated patient or a stressful family situation, but when we look to get support from others, that support is either not there at all, or there are other stressed people who are reacting negatively to us. And that causes us to become much more antisocial. In fact, then, what it means is that our affiliate response is lost to us, leaving us with only fight or flight or freeze as the ways that we can respond to the stressful situation. So what does that mean? Is that it's going to turn on and turn up the cortisol and epinephrine pumping through our bodies. And those effects are going to primarily impact cortisol hitting particular parts of our brain and particular parts of our bodies. There's impacts on our prefrontal cortex and our amygdala, which turns up our alarming, making us much more reactive. There's also impacts on our reticular activating system. This is a part of our brain which causes us to be alert and stay awake. You know, when there's a tiger coming at you, it's not a good time to take a nap, especially if there's no other humans who are going to help you. So under threat, we actually have a response to that cortisol where we become much more wakeful. It becomes much more difficult for us to sleep. And in fact, many of you who have dealt with COVID-19 will recognize that they're beginning to call it COVID-19 insomnia, that many of us have had this response to the COVID-19 pandemic. This increase of cortisol also impacts our immune system, because fundamentally what a surging of cortisol means to the body is that we are getting ready to deal with a predator, not getting ready to deal with the flu or COVID-19. So in fact, under constant threat, we actually have a turning up of our inflammatory mediators and a turning down of our humoral immune system, or our ability to fight infection. If that is left unchecked over time, that increase in the inflammatory response appears to impact a part of the brain which can cause a form of depression. It also impacts us such that we begin to have what's called the sick syndrome. Under threat, our best bet is to actually stay in our cave, right? If there's a tiger pacing outside your cave, you should just stay in the cave, don't come out. But unless the governor has given a stay-at-home order, most of us would go out of the cave unless we felt terrible. And so as a safety mechanism under threat, the body gives you this feeling of unwellness, a headache, a stomach ache. And many of you will recognize this, that under threat, you wake up in the morning and you don't say, zippity-doo, today's my day. You feel lousy. You have a headache. You have a stomach ache. Well, now let's go back to some of these symptoms of burnout and think about how that may be related to this increase in the stress responses. Sleeplessness related to the stimulation of our reticular activating system. Frequent illness impacted by this impact on our immune system from the cortisol. Depression and irritability with coworkers related to this form of depression that happens related to inflammatory mediation on the brain. Forgetfulness and this working hard and feeling drained may be directly related to impacts on the prefrontal cortex from an overload of cortisol, which takes the prefrontal cortex and working memory and cognitive flexibility offline as we try to deal with threat. Many of you will recognize that in especially the early days of COVID, you would spin and feel like you couldn't get anything done. You just were spinning around and around and couldn't focus on anything. Then, if we think about not just the cortisol impacts, but when there is an incredible surge of this fight or flight response and we have this epinephrine impact, we can think about some of these symptoms of secondary traumatic stress, that epinephrine is going to promote this increased heart rate and difficulty breathing, this hypervigilance and elevated startle, which we can see when our sympathetic nervous system is stimulated. So if that is true, it bears thinking about that affiliate response relies on relationships or the attachments that we have. We talk about this in our course on child trauma because it's true for kids who've experienced threat. But for those of us who work with kids and families in the healthcare setting, we also rely on the relationships or attachments in our workplace in order to manage the threats that we're dealing with. And if that's true, how does that impact how we think about solutions? If we want to reduce this stress, we may want to think about ways to shut it down from the top. How do we reduce the amount of stress coming at us in the first place? Do we need to think about how large our panels are, how many patients we're expected to see in a day, how frequent call schedules are that are going to put us at risk for having a stimulation of the stress response in the first place? Interestingly, when we look at the literature on burnout, there are a couple of efforts to improve burnout that have been shown to be most successful. One is team-based care, and the other is attention to using EPIC more efficiently and what's called getting rid of the stupid stuff. One of the things that they have found when they look at studies of the electronic medical record is that clinicians tend to be on electronic medical records certainly during the day, but after dinner there's a bumping up as people go back on to finish their notes, and on Saturday nights there's another bumping up because date night belongs to EPIC. And as they have improved efficiencies of EPIC and as they have developed teams to manage patients, they've seen a change and a reduction in burnout symptoms in medical team members. There's also the effects of addressing the freeze and fight or flight response. And that may be exactly where we started with yoga and meditation and mindfulness, where if we can focus and use our bodies to stimulate the parts of our body that stimulate relaxation. So guided meditation or muscle contracting, stimulating deep proprioceptive centers to promote relaxation. Breathing, stimulating vagal nerve to also stimulate relaxation may have some great effect at impacting freeze or fight or flight. But I think the most effective things that we will do is to approach the affiliate response. And how do we promote improving that ability to look left and right and find that support so that we can use this oxytocin-mediated response to calm? Interestingly, I would take us back to some of the solutions that have already been mentioned in the burnout literature. When team-based care and the electronic medical record maximization is brought up, it is indicated that those are beneficial in burnout because they promote efficiency. But I think there's an interesting case to be made that when we do team-based care, we create the group of people who are going to tend and befriend you in your immediate work environment. There's a very clear delineation of who's going to help who. And so I think it's not just efficiency, but you're actually promoting this affiliate response. When we create efficiencies in the electronic medical record and have no more stupid stuff, you free up the time for people to spend time with their families and those who they're supposed to be sharing their downtime with, instead of forcing them away from those affiliate relationships that could be calming and soothing. Interesting, there's also data looking at the role of an immediate supervisor and the effect of a regular opportunity to go to dinner with colleagues. So let's unpack those for a minute. There's some very interesting studies in the research on burnout which look at the fact that in medicine, a first-line supervisor, their behavior has a 30% effect on burnout, although there has to be follow-through with upper-level leaders. And what they found is that oftentimes for people in the medical field, be it physicians, nurses, social workers, other professionals within the healthcare setting, first-line supervisors are often the person who is just there longer or who was a really good clinician, but they're not people who've been particularly trained to do supervision. In fact, a supervisor who can do 4 things: recognize someone for a job well done, facilitate career development, keep the provider informed, and ask their opinion, can lower burnout and improve the sense of wellness for medical providers most significantly. That's tend and befriend. That's the affiliate response. Because when we're looking for support, most frequently we look to our first line supervisor to be the person to provide that affiliate support. And so having trainings and thinking about the role of that first line supervisor in doing these supportive activities may be an excellent way for us to think about reducing burnout. There's also some support that happens in the interactions that we have with colleagues. There was some interesting studies looking at in a program where they had colleagues go to dinner with each other. And when I first read this study, I thought, really, we've poured all this money into this problem and the answer is to go to dinner with each other? But if you think about what that means, it means that we take ourselves out of the stressful situation and we build the relationships that are going to be the most supportive. And what we find is that if you have regular interactions with work colleagues, you have more meaning in work and a decrease in burnout symptoms. Finally, if we look back into secondary traumatic stress literature, we also find that the strategies which have been most effective in preventing secondary traumatic stress also have a huge affiliate component. Promoting psychoeducation, promoting skills training, and supervisory support are considered the top 3 ways to reduce secondary traumatic stress. And if we think about what those actually mean, in every one of them, there is a direct attempt to tend and befriend the person who's feeling that secondary traumatic stress and to bring them back into the fold of work, recognizing that they have a greater support network than they may have previously believed. But I think for all of us, the other thing that we can think about is the fact that as we witness suffering and we realize the effects on you, we can also recognize the effects of working with the kids and the families who are demonstrating their resilience. And remember that in our unique profession, we have this incredible ability to tend and befriend our patients and families, and in turn, we are often tended and befriended by them. And so we can come out of these situations perhaps not just not damaged, but in many instances with our resilience built. I have a list of references that may be useful to you, and I'd be happy to answer any questions.